welcome to the deep dive. Today we're heading into a truly fascinating and somewhat unusual area of medicine. Anesthesia in a hyperbaric environment. Most of us don't often think about being in a pressurized chamber for treatment, right? But the idea of needing anesthesia while you're in one. Okay, let's unpack this because it brings up some, really interesting challenges.
It really does.
We've got a detailed chapter from a medical text that explores this topic in depth. And our mission today is to sort of understand why this is done, how it works, and, well, what makes it so different from giving anesthesia in a regular operating room.
Yeah, and it's pretty remarkable when you look back at the history, which our source material does. The concept isn't exactly new.
Yep.
No, as early as 1878, Paul Burt was already experimenting. He used nitrous oxide under pressure. The idea was to give anesthesia, but also make sure the patient had enough oxygen.
Wow, 1878.
Yeah, that early work really kind of set the stage.
Exactly. And it seems like the real push for hyperbaric anesthesia picked up later, maybe mid-20th century, like the 1940s and 50s.
That's right.
This was during that big boom in cardiac surgery, especially for fixing congenital heart defects. I'm thinking like the Blaylock procedure for tetralogy of Fallot.
Right. Those were incredibly complex surgeries inside the heart. And back then, they often relied on things like hypothermia, lowering body temperature, and briefly stopping blood flow.
Right.
And the big limitation, the real sticking point, was that very short window of time, usually less than 10 minutes, where you could stop circulation safely before risking, significant brain damage.
Right. A huge constraint.
Huge. And this is where hyperbaric oxygen combined with anesthesia offered a significant advantage.
How so?
By boosting the oxygen available to the tissues, it essentially provided a buffer. It could potentially stretch that safe cardiac arrest time out to around 30 minutes.
30 minutes. That's a massive difference.
Absolutely massive. And the chapter highlights some key players involved in this early research.
Yeah. Like who?
People like Smith at Mass General, Borema over in Holland, McDowell in Glasgow. They were all looking into how to deliver anesthesia effectively under these pressurized conditions.
Okay.
And the anesthetic drugs they were using back then, nitrous oxide, halothane, methoxyflurane, names we still recognize.
Sure. But things change in medicine, right?
They always do. As often happens, progress in one area affects another. The big game changer was the cardiopulmonary bypass machine.
Ah, the heart-lung machine.
Exactly. Once that became widely available in the mid-60s, surgeons could operate on a still heart for much longer periods without needing the extra oxygen boost from a hyperbaric chamber.
Okay, so the initial big reason for hyperbaric anesthesia in heart surgery kind of faded away then.
Pretty much, for routine cases anyway. They tried applying it elsewhere, like for carotid endarterectomy.
Cleaning out the neck arteries?
Yeah, but it didn't really show significant benefits there either.
Interesting. The source also mentions a report, the Severinghaus Committee report from '65.
That was quite pivotal. It didn't say use this drug, but it laid out the pros and cons of different techniques.
And what did it suggest?
Well, interestingly, it suggested that intravenous anesthetics, drugs given through an IV, might be particularly suitable for the hyperbaric environment.
Okay, sort of foreshadowing current practice.
You could say that, because fast forward to today, and the reasons for using anesthesia in a hyperbaric chamber are much more specific, much more targeted.
Right. So what are the main uses now?
Well, currently, the main situations are, first, for patients who have significant but temporary drops in their oxygen levels, transient hypoxemia, and are undergoing treatments like whole lung lavage.
Washing out the lungs, essentially.
Exactly. These procedures usually happen at pressures of about 2 to 4 atmospheres absolute, or ATA, so 2 to 4 times normal sea level pressure.
Okay. And the other main scenario?
That's for emergency surgery on people involved in diving accidents. They might still be under significant pressure, potentially up to 35 ATA in some cases.
35 times normal pressure. That's intense.
It's incredibly high. Think deep commercial diving depths.
Wow. The chapter even mentions some really high-pressure research, right? Like over 100 ATA in rats. Something about reversing anesthesia.
Yeah, 103 ATA in rats, looking at pressure reversal of barbiturate anesthesia. It's scientifically fascinating stuff.
But not clinically relevant for us.
Well, the author makes that point quite clearly. It has limited direct clinical relevance because even in the most extreme therapeutic hyperbaric treatments we use for humans, we rarely exceed 6 ATA.
Okay, 6 ATA is more the upper limit in practice?
Generally, yes. But that high-pressure research does show just how profound the effects of pressure can be on biological systems. I mean, consider this. Humans have actually survived experimental exposures up to 69 ATA at Duke University.
69. Okay, that really puts the clinical pressures into perspective.
It really does.
All right, so let's dig into some of the unique physical considerations. Delivering anesthetic gases under pressure. How does that work differently?
Well, as the chapter explains, modern vaporizers work by passing a carrier gas, like oxygen or air, through a liquid anesthetic.
Okay.
And the amount of anesthetic vapor that gets picked up and delivered depends on a few things. The anesthetic's vapor pressure, the temperature, the gas flow rate, and how much it's diluted.
Standard stuff so far.
Oh.
But what changes under pressure?
Okay, here's a really key point, highlighted way back in 1952 by Morris. The vapor pressure of the liquid anesthetic itself doesn't change just because the surrounding ambient pressure goes up.
The liquid's tendency to evaporate stays the same.
Right. But while the partial pressure, think of that as the push exerted by just the anesthetic gas within the mixture, might stay the same for a given vaporizer setting, the actual concentration of that anesthetic in the total gas mix can change, sometimes dramatically.
Okay. Can you give an example?
Sure. Take halothane. At 20 degrees Celsius, its vapor pressure is 243 millimilli Hg. At normal pressure, 1 ATA, that vapor pressure might mean it makes up, say, 32% of the gas coming out of the vaporizer if you saturate the carrier gas. But now, take that same vaporizer setting, that same 243 milli Hg partial pressure of halothane, and put it at 4 times the atmospheric pressure, 4 ATA. Now, that same partial pressure only represents 8% of the total gas mixture.
Whoa, so the percentage drops significantly even though the amount of anesthetic push is the same?
Exactly. But here's the tricky part for delivery.
Yeah.
To get a clinically useful partial pressure often requires a much lower percentage setting on the vaporizer at depth than at the surface. However, some older vaporizers weren't pressure compensated, meaning if you set them to, say, 1% at the surface, they might actually deliver a gas mixture where the partial pressure corresponds to 1% of the total ambient pressure. So at 4 ATA, that 1% setting could deliver 4 times the dose you intended.
Yikes. Okay, so that's a major potential issue.
It is. The chapter mentions some empirical findings with specific vaporizers, the Fluotech ones, under pressure. They found that at low settings, like 0.5 to 1%, when used at 2 ATA, they could actually deliver almost double the concentration you'd expect based on the dial setting. Yeah. Higher settings seemed more consistent, closer to what you'd get at 1 ATA. But the crucial takeaway is you absolutely cannot just dial in a percentage on the vaporizer and assume you're getting the same effect under pressure.
Got it. Constant vigilance and monitoring are key. What about flow meters, the things that measure gas flow?
Right, rotameters, they're affected too. They basically work by floating a bobbin in a tapered tube. The higher the flow, the higher the bobbin floats.
Okay.
But under pressure, the gas gets denser.
Right.
And that increased density affects how the bobbin floats. Especially at higher flow rates, the density is the main factor. At lower flow rates, gas viscosity plays more of a role.
So the reading isn't accurate.
It's not. Because the gas is denser, it lifts the bobbin more easily for a given actual flow rate, so the flow meter will overread. It tells you you're giving more gas than you actually are.
Okay, that's the opposite of what I might have guessed. More density, more lift on the bobbin.
Exactly. There's actually a formula to approximate the correction. F1 equals F0 times the square root of D1 over D0.
Let's break that down.
F1 is the actual flow at the higher pressure. F0 is what the flow meter indicates. And D1 and DO are the gas densities at the higher pressure and normal pressure, respectively.
Okay. And the example given is pretty stark, right? At 4 ATA.
Yeah, 4 ATA, the actual flow, F1, is roughly half of what the flow meter is reading.
Half. So if your flow meter says 10 liters per minute, you're only actually delivering about 5.
Approximately, yes. It really underscores that you can't just trust the numbers on the dials in a hyperbaric setting. You have to understand the physics and apply corrections.
Absolutely critical. Okay, so beyond just the physics of the gases, what about the physiological effects on the patient? High pressure, high oxygen. It's got to do things to the body.
Oh, definitely. The increased pressure and, maybe more importantly, the high concentrations of oxygen used in hyperbaric therapy have significant effects. Let's talk about the respiratory system first.
Okay. Lungs.
The chapter warns about prolonged exposure to high oxygen levels, even at relatively low pressures like 1 or 2 ATA. If you're breathing, say, 90, 100% oxygen for 24 hours or more.
Which can happen during some HBO treatments, right?
It can. This can actually damage the lining of your airways, the tracheobronchial mucosa. It can lead to increased secretions, more mucus, and even atelectasis, which is basically the collapse of tiny air sacs in the lungs.
Okay. And that's worse for people with existing lung problems.
Exactly. It's a concern for anyone, but especially if you already have something like asthma or COPD. The irritation from high oxygen can also make procedures like intubation trickier, increases the risk of laryngospasm.
That sudden tightening of the vocal cords, yeah, makes sense.
And for COPD patients, it's even tougher. Their airways are already narrowed, add in more secretions, plus the increased effort needed just to breathe the denser gas. It can cause real problems with ventilation.
And what about decompression? Coming back up to normal pressure?
That poses its own risks. If someone has pulmonary bullae, these are like weakened, air-filled blisters in the lung tissue, or if mucus plugs an airway, then as the ambient pressure drops during decompression, the air trapped behind the blockage expands. This is Boyle's law in action. It can lead to rupture, a collapsed lung, pneumothorax, or even air getting into the bloodstream and air embolism.
Yeah.
That's barotrauma.
Serious stuff. The chapter mentions vital capacity decreasing.
Right. Vital capacity, the maximum amount of air you can breathe out after a full breath in, it can decrease. And that's seen as an index of atelectasis developing due to oxygen exposure. They even quantify it using something called UPTD units of pulmonary toxicity dose.
Okay. Is that damage permanent?
Thankfully, the reduction in vital capacity seems to be reversible once the high oxygen exposure stops.
Yeah, that's good news.
Also interesting is the mention of a loss of pulmonary surfactant under HBO. Surfactant is that substance that keeps the air sacs open.
Right, prevents them from collapsing.
Losing it contributes to atelectasis. But the good news here is that properly humidifying the gases the patient breathes seems to offer some protection against the surfactant loss.
Okay, so humidification is important. You also mentioned the increased work of breathing.
Yeah, because the gas is denser at higher pressure, the flow in the airways becomes more turbulent, less smooth. That takes more effort.
Makes sense. Any way to mitigate that?
A key practical step is to use the largest possible endotracheal tube that's appropriate for the patient. A wider tube means less resistance.
Got it. Okay, what about the cardiovascular system? Heart and blood vessels.
High oxygen levels in the blood cause significant peripheral vasoconstriction.
So blood vessels in the arms, legs, skin tighten up.
Exactly. Which, interestingly, has implications for giving meds. The chapter specifically advises against intramuscular or subcutaneous injections.
Why?
Because that vasoconstriction might slow down how well the drug gets absorbed into the circulation.
Okay. Stick to wife.
Generally, yes. Now, counterintuitively, while peripheral vessels constrict, the resistance in the blood vessels of the lungs, the pulmonary vascular resistance, actually seems to decrease.
Interesting difference.
But a potentially concerning effect is coronary vasoconstriction.
Narrowing of the arteries supplying the heart muscle itself.
Yes, and reduced blood flow through those arteries. This means we need to be particularly cautious with anesthesia under HBO for patients who already have coronary artery disease.
Definitely. Any effect on how hard the heart pumps?
Some studies show a modest decrease in cardiac output, the amount of blood pumped per minute. Probably because the heart is pumping against that increased peripheral resistance, the afterload.
That makes sense.
But animal studies haven't shown significant changes in the actual contractility, the pumping strength of the heart muscle itself at typical therapeutic pressures like 3 ATA.
Okay. What about the brain? Central nervous system.
Oxygen is also a potent vasoconstrictor in the brain. Affects vessels on the surface and deeper arterioles.
Could that ever be good?
Potentially, yeah. In specific situations like closed head injuries or maybe brain tumors, that vasoconstriction might help reduce brain swelling.
Okay. But downsides?
Well, there's a concern about potentially lowering the seizure threshold during general anesthesia under HBO.
Making seizures more likely.
Possibly, especially for patients already at risk. The recommendation is to consider prophylactic anticonvulsant drugs if you're going to pressures of 3 ATA or higher.
Got it. Preventative measures.
And we should also mention inert gas narcosis.
Nitrogen narcosis, right, like divers get.
Exactly. If you're breathing air at 2 ATA or more, the increased partial pressure of nitrogen can have effects similar to alcohol intoxication, drowsiness, maybe euphoria, definitely impaired judgment.
But patients under anesthesia in the chamber usually aren't breathing air, right? They're on high oxygen.
Correct. So they're typically not at risk for nitrogen narcosis itself, but it's part of the whole picture of gas effects under pressure.
Okay, so let's talk about specific anesthetic agents. The chapter mentions that nitrous oxide study again.
Yeah, the Russell study from 1990 at 2.0 ATA. Healthy volunteers. They used 75% nitrous oxide, 25% oxygen, intubated them, let them breathe spontaneously, monitored EEG and gases.
And what did they find? What was nitrous anesthesia like under pressure?
It was eventful, characterized by high blood pressure, fast heart rate, rapid breathing.
Okay.
Bursts of sympathetic nervous system activity, that fight or flight response, and even occasional muscle clonus and epistotonus, which is like severe muscle spasms causing arching of the back.
Yikes. Doesn't sound ideal.
Not really. They didn't see long-term problems afterwards, but the conclusion was pretty clear. It's just not a practical technique for clinical use. Although it did help refine the MSC, the minimum alveolar concentration needed for anesthesia for nitrous under pressure. Turns out it's more potent than we thought, maybe closer to 1.2 ATA needed for MS.
Interesting. So if not nitrous, then what? You mentioned IV anesthesia earlier.
Right. Intravenous anesthesia seems to be the way to go. The chapter mentions Ross and colleagues advocating for it early on, partly because they were worried about anesthetic gas leaking into the chamber environment at high pressures.
Pollution concerns, basically. Makes sense.
And there's documented success. Used ketamine anesthesia for open heart surgery with oxygen at 3 ATA back in '87.
Ketamine. Okay.
And others, Moon and Camporese, used a combination of ketamine and benzodiazepines, plus muscle relaxants for those therapeutic lung lavages we talked about. Did about 20 cases without complications reported.
So IV seems much more manageable. Do we know if the pressure affects how the body handles these IV drugs, their pharmacokinetics?
That's a key question, but the data is pretty limited, unfortunately. Most of what we know comes from animal studies.
Okay, what did they find?
Studies looking at drugs like meperidine, Demerol, and pentobarbital in animals at pressures up to 2.8 or even 6 ATA didn't find significant differences in things like drug half-life, volume of distribution, or how quickly the plasma cleared the drug.
That's reassuring.
It is. It suggests that we can probably use our common IV anesthetics carefully within that typical therapeutic range of 2 to 6 ATA without expecting major pharmacokinetic surprises.
And that pressure reversal thing,
Yeah.
where high pressure counteracts the anesthetic.
Right. They specifically looked for that with pentobarbital at 1, 2.8, and 6 ATA and didn't detect it. It seems that phenomenon is unlikely to be clinically significant at pressures below, say, 50 ATA, way higher than we use therapeutically.
Good to know. Okay, let's shift to the really practical stuff. Being inside the chamber, giving anesthesia. What are the challenges? Noise, for one.
Oh, yeah. Big one. The chapter highlights the significant noise during compression and decompression.
And the pressure is changing.
Exactly. And that noise can make it really hard to hear things through a stethoscope or even hear monitor alarms clearly. And those pressure change periods are often when you need to be most vigilant.
So a real hurdle for monitoring. What about basic airway equipment?
Hmm.
Laryngoscopes, tubes.
Laryngoscopes generally work fine as long as the battery handles are vented so pressure can equalize. Even sealed batteries apparently work up to 35 ATA.
Okay.
And as we mentioned before, using the largest appropriate endotracheal tube is really important to minimize that increased work of breathing from the denser gas.
Makes sense.
And here's a simple but critical practical tip. Inflate the cuff on the endotracheal tube with saline, not air.
Why saline?
Because the volume of air in the cuff would shrink during compression and expand during decompression due to Boyle's law.
Yeah.
That could lead to a leak when you need a seal or potentially too much pressure on the trachea. Saline is liquid, it's not compressible like air, so its volume stays stable.
Ah, clever. Okay. Ventilators, breathing machines, big challenges there.
Definitely. First off, fire risk. With high oxygen levels, you want to minimize any electrical equipment inside the chamber.
Right. Sparks and oxygen don't mix.
Not at all. So compressed air-driven ventilators are preferred. They work based on a pressure difference, usually around 50 psi above the chamber pressure.
Okay. Do they work the same under pressure?
Mostly, but they might deliver slightly lower peak flow rates if the pressure difference driving them isn't maintained perfectly. More importantly, though, is oxygen leakage from the ventilator.
Leaking into the chamber atmosphere?
Yes. Especially in multi-place chambers where staff are inside too, you have to keep the ambient oxygen level below about 23% to minimize fire risk.
So you need special low-leak ventilators.
Exactly. And systems to scavenge or vent any leaked oxygen safely outside the chamber. Also crucial. No oil-based lubricants anywhere near the oxygen systems. You need special oxygen-compatible lubricants like those based on PTFE.
Okay. Are the ventilators known to work well?
The chapter mentions one specific model, the Monaghan 225, which was used successfully up to 6 ATA after some minor modifications.
Good to know specific examples exist. So with all these variables, gas, physics, physiology changes, equipment quirks monitoring must be absolutely paramount.
Paramount is the word. The chapter really stresses this. Because hyperbaric anesthesia isn't routine, there aren't standard cookbooks or dose adjustments. You have to titrate everything to the individual patient's response at that pressure.
Tailored approach. What kind of monitoring is essential?
Standard vital signs, of course, but for any prolonged anesthetic, an arterial line is highly recommended.
The line directly in an artery.
Yes. Gives you continuous, accurate blood pressure, second by second, and easy access for blood sampling.
Okay. But sampling blood has issues too, right? You mentioned bubbles.
Right. Measuring arterial oxygen inside the chamber is tricky. If you draw blood and bring it out, gas can bubble out of solution as the pressure drops, messing up the readings. Plus, standard blood gas analyzers aren't really calibrated for the super high oxygen levels you might see.
So what's the workaround?
Ideally, keep the blood gas machine inside the chamber or in a pressurized pass-through lock, but that means you need trained staff inside to run it.
Yeah, always feasible.
No. So pulse oximetry becomes really valuable, that little clip on the finger.
Non-invasive gives oxygen saturation.
Exactly. The cables can be passed safely through the chamber wall. It's especially useful if the patient has lung issues causing shunting.
What about monitoring the gases they're actually breathing?
You can use respiratory mass spectrometry. A sampling line goes through the chamber wall to an analyzer outside, giving you continuous readings of inspired and expired gas concentrations.
Okay, sophisticated stuff. What about brain monitoring? Seizure risk.
CNS, oxygen toxicity, seizures, it's rare at typical therapeutic pressures like 2.8 ATA. But for longer cases or higher pressures, or if the patient is paralyzed with muscle relaxants which would mask convulsions.
And you can't see a seizure starting.
Right. In those cases, EEG monitoring looking at brain waves is advisable. It can detect seizure activity even if there are no visible signs.
Good point. ECG for the heart is standard.
Standard, yes. Usually the monitor itself is outside, viewed through a porthole, with leads passed through pressure-tight connectors. Flat-screen monitors inside are becoming more common now, too.
And if the worst happens, can you defibrillate inside the chamber?
Yes, it's feasible. The chapter mentions using a specific adapter on a defibrillator unit. Self-adhering pads are preferred over paddles to reduce any risk of sparking near the patient.
Safety first.
Always. Standard paddles can be used with careful technique and low resistance gel, but pads are safer. And things like neuromuscular monitors, checking muscle relaxation, they're low amperage, generally safe inside.
One key safety measure for electrical gear.
Any electrical equipment used inside must be designed for hyperbaric use and often flushed with nitrogen or housed in special enclosures to create an inert atmosphere in case of any internal sparks.
Okay, very stringent safety. Now, there's one more really crucial practical point mentioned. Prophylactic myringotomy.
Ah, yes. Absolutely crucial.
What is it and why?
It's making a small incision in the eardrum. The strong recommendation is to induce anesthesia at normal pressure, 1 ATA, then perform bilateral myringotomy on both ears before you start pressurizing the chamber.
Why before pressurizing?
To prevent middle ear barotrauma. As the pressure increases, air needs to get into the middle ear space via the eustachian tube to equalize pressure. If that tube doesn't open easily, which is common under anesthesia, the pressure difference builds up across the eardrum, causing pain and potential damage. The myringotomy creates an open path for pressure to equalize instantly.
Makes perfect sense. Much better for the patient than trying to induce anesthesia while they're dealing with ear pain during compression.
Exactly. An alternative is having tympanostomy tubes, little ear tubes, put in beforehand under local anesthetic. That also works safely.
Got it. Okay, let's try and wrap this up, bring our deep dive together.
Sure.
It's clear anesthesia in a hyperbaric chamber is, well, highly specialized, not common, but absolutely vital for certain life-saving HBO therapies.
Absolutely. And the recurring theme, the absolute constant, is meticulous attention to detail. every single step.
And the preference is generally for IV anesthesia.
Yes, whenever possible. Drugs like ketamine and benzodiazepines, often with muscle relaxants, seem useful for both induction and keeping the patient asleep.
And avoid inhalation agents if you can.
Generally, yes. Mainly due to those concerns about gas leakage into the chamber and exposing the team.
And remember, standard recipes don't work. You have to titrate the anesthetic based on how the patient is responding at that specific pressure.
Precisely, not based on sea-level formulas. But it is reassuring that major pressure reversal effects are unlikely up to that 6 ATA mark.
And don't forget the myringotomy before you pressurize.
Cannot stress that enough. Also, using a nasogastric tube is a good idea.
Why the NG tube?
If you use a mask for ventilation initially, you can introduce air into the stomach. As you go to depth, and then especially during decompression, that trapped gas expands. It can cause bloating, breathing difficulties, even low oxygen levels. The NG tube lets you drain that air out.
Smart. Okay. And if you do have to use gas anesthesia?
Volatile agents like sevoflurane or isoflurane are generally preferred over nitrous oxide, especially for longer cases.
Because of decompression sickness risked with nitrous?
Exactly. Nitrous dissolves readily in tissues and can come out of solution quickly during ascent, potentially forming bubbles.
Okay. The chapter even touches briefly on patient transport.
Yeah, just to mention that the anesthetist might be involved in transferring patients who need HBO, maybe by helicopter or pressurized plane, and needs to consider things like hydration and sedation during the transfer.
Right. So ultimately, the anesthetist is a really key part of the hyperbaric team, especially in emergencies.
Absolutely vital, particularly in hyperbaric emergencies like an air embolism during surgery. That specialized monitoring and physiological understanding is critical.
So there you have it, a deep dive into the fascinating and pretty complex world of anesthesia in the hyperbaric environment. It's a perfect example, isn't it, how a seemingly standard medical procedure gets way more intricate when you dramatically change a fundamental environmental factor like pressure.
It really highlights the adaptability needed in medicine and the specialized knowledge that builds up in these niche areas.
Definitely. Maybe this has sparked some curiosity for you, the listener, to explore hyperbaric medicine more broadly in its diverse applications. Thanks for joining us on the deep dive.
Yeah, thanks for tuning in.
And maybe consider this. How does our basic understanding of physiology and pharmacology get tested, get refined, when we push the boundaries like this? Altering something as basic as ambient pressure. It's a reminder that even things we think we know well require constant reevaluation when the circumstances change.